Hi guys, welcome back to the channel. Last class we have started with florid cemento osseous dysplasia. We have seen that is a set of radiolucent, radiopaque, that is mixed periapical and interradicular lesions involving the mandible bilaterally. Then we have seen it is an extended form of periapical cemento osseous dysplasia. Same thing, we have also seen that it is asymptomatic and it is a dysmorphic bone cementum complex, and it is more common in women. African heritage is more commonly affected and the age is around 40 years. Okay, we'll be continuing florid cemento osseous dysplasia. Let's start. Radiographs show large radiolucent, mixed or most often dense radiopaque masses limited to periapical alveolar bone. They do not involve inferior border neither rami. They also involve the interradicular bone up to the level of CEJ. Okay, we have seen it involve both interradicular and periapical alveolar bone, but they do not involve the inferior border neither rami. They involve mandible bilaterally, but they do not involve the inferior border or neither rami. What are the differential diagnosis of florid? First is Paget's disease, but Paget's disease, how will we differentiate that? It is almost similar. Florid cemento osseous dysplasia and Paget's disease radiographically is almost similar, so we can identify it by alkaline phosphatase determination. It will be present in Paget's disease, not in florid cemento osseous dysplasia. Second is multiple endoosteomas in Gardner's syndrome, ossifying fibroma, and chronic osteomyelitis. These are the differential diagnosis. Now, diagnostic workup requires clinical and radiographic diagnosis same. No biopsy is needed, nothing is needed. Only clinical and radiographic correlation will help in the diagnosis of cemento osseous dysplasia. Now, coming to histopathology. Unencapsulated fibroblastic tissue with irregular osseous trabeculae and acellular cementon-like material. Both osseous and cementon-like material are present, but it is irregular osseous trabeculae and acellular cementum is present. Now, sclerotic acellular avascular masses develop. सेम पेरियापाइकल में भी ऐसा होता था कि इवेंचुअली इट विल डेवलप इनटू स्क्लेरोटिक एसेलुलर एवास्कुलर मास. In this we can also appreciate idiopathic bone cavity. Second, inflammatory infiltrate and fibrosis can be seen when it becomes symptomatic. Okay, when it is affected we can see inflammatory infiltrate and fibrosis. Now coming to treatment plan. Asymptomatic florid cemento osseous, when it becomes symptomatic, it will show inflammatory infiltrates and fibrosis. Okay, now coming to treatment. Asymptomatic florid cemento osseous dysplasia is not treated. It should remain जैसा है वैसा छोड़ दो. It should not be treated. All attempts to salvage teeth should be exhausted before a tooth associated with opaque lesion of this type around its root is removed. Teeth को salvage करना या कोई भी treatment attempt should not be there. Okay. If in such case tooth is removed, it will lead to secondary infected wound and the onset of pain and discharge. Now, that was about asymptomatic. Coming to symptomatic, secondarily infected may be alleviated with local wound care and antibiotic therapy. Antibiotic therapy और wound care से हो जाएगा. But if persistent cases often respond better with HBO therapy, that is hyperbaric oxygen therapy, which enhances the microcidal ability of the host defense, and antibiotics in such poorly vascularized tissue. As it is avascular, acellular, HBO therapy is of great help. Now, if symptomatic exacerbation reoccur, मतलब वापस हुआ, तो then surgery, that is alveolar resection of symptomatic area is necessary. अगर वापस हुआ then surgery is the last option. ये वापस रिकर हुआ सिम्टोमेटिक एक्सर्वेशन, देन नेसेसरी सर्जरी, वो भी एल्वियोलर रिसेक्शन ओनली ऑफ द सिम्टोमेटिक एरिया. That's all for today's class. We'll be continuing this in the next class. Till then, like, share, subscribe and comment. Bye.